Okay, hi everybody. My name is Abby Sweet. I am the Population Health Manager for the East Central region. Excited to be meeting with all of you today to talk about HCC documentation. I'll be reviewing a PowerPoint slide and then be on at the end to answer any questions that you may have. If at any point you have questions during the presentation, please stop it or please stop me and let me know. I'm getting a little bit of an echo. If you wouldn't mind putting yourself on mute if you're not muted, unless you have a question, then of course you can unmute. And I'll share my screen. Okay. Can you guys see this okay?
Yes, we can see it.
Okay, perfect. Thank you. Okay, so what is an HCC code? So hierarchical conditional categories are a model of risk adjustment, a payment model of risk adjustment that stratifies Medicare beneficiaries on the basis and number of severity of chronic conditions. You wouldn't mind muting yourself if you're unmuted. Thank you. Okay, it assigns weight to each clinical grouping to account for severity and attempts to capture the beneficiary's health status so they will be reimbursed accurately. There are 79 HCC categories that are mapped to over 3,000 ICD-10 diagnosis codes, and the HCC factors take in, disease groups, disease hierarchies, age, sex, demographic factors as well. So HCC documentation, so improving the documentation rate will affect the risk score for a patient. So each patient is assigned a risk score that is weighted and added to determine the patient's overall score. So it's normalized to an average population. So if you have a patient who's of average health risk, they'll have a risk score of 1. But if they're at greater risk, they might have a risk score of, 1.5. Patients even, have risk scores much higher than that, 2.7, even up to, a 12. And then if they have lower than 1, they're considered at lower risk, so a healthier individual than the average. So risk scores adjust the reimbursement budget that we get from CMS for these patients based on the risk score of the patient. And so without appropriate risk adjustment, there's a divide between how we might see our patients and how CMS could see the patient. So we might see this patient on the left who, has a ton of utilization, is in and out of the hospital, has a ton of comorbidities and chronic conditions. But if we're not accurately capturing those chronic conditions on an annual basis, CMS may view the patient as the patient on the right, who's a very healthy, active patient who doesn't have a ton of chronic conditions. So what is the why behind HCC coding? So it's good for the health of the community. So max reimbursement means that we as a system have resources to put back into our communities and develop different clinical programs like complex care. We have Clicatine that helps with tobacco cessation. We've been able to do, community paramedic, Aunt Bertha, which connects patients who need resources to resources within their communities. And again, that reimbursement just helps us to identify, reach, and impact the health of our patients with varying degrees of need, whether that's, their physical health or their social well-being. And it's good for physicians. So the process puts processes in place to help capture a complete 360 view of the patient so we can be fully informed in our medical decision making. So it's good for our patients. Patients should be assessed, treated, and cared for based on their complete health profile, not just the relevant conditions of the day. And then it's also good for IU Health. So CMS will pay more to care for patients with significant health conditions. So if we are accurately assessing and capturing all of our patients' chronic conditions, we can earn what's available from CMS for treating these patients. Improved accuracy means accurate reimbursement, which again ties back to having those funds to put back into programs that benefit our patients' overall well-being. So the impact of documentation on revenue, you can see this is just an example. This patient here is an 85-year-old white female with symptoms of a UTI who has a significant past medical history. But if we have limited documentation on this patient, you can see there her total HCC may come out to 0.8, which is again less than that 1. And so this patient, even though she has a significant past medical history, history of an MI plus this UTI she's got going on, she may seem healthier than what she actually is. So, and then if you go down to the annual risk adjustment revenue for that limited documentation, we would only get about $7,700 to care for this patient per year. Whereas if we have thorough documentation of this patient, you can see her diabetes with CKD stage 5, malnutrition, history of an MI, BKA, all of these different things, plus her demographic HCC. Her total HCC now would be 2.7, which is significantly higher than that 1, which shows that she is an at-risk individual. So the risk adjusted revenue here is $26,000, which is, again, significant difference between the $7,700, which allows us to have those resources to put back into our patients. So how do we have appropriate documentation for HCCs? So we use MEET criteria, which I'm sure you've heard before. So monitoring the signs, symptoms, disease progression and regression, evaluating our patients through test results, medication effectiveness and treatment response, assessing and addressing these conditions. So ordering tests, discussing with patients, records review, counseling, and then of course, treating with medication therapies or other modalities. So appropriate HCC coding is a 4-step process. So assess, evaluate, and treat your patient's health conditions, document patient's health conditions specifically and accurately to ensure they're getting the correct risk adjustment score to them, and then incorporating appropriate conditions into the patient's problem list and validating annually. So it's not only, addressing conditions that are appropriate to the patient, but also removing conditions or rejecting conditions that are no longer applicable to the patient. And then continuing with all other aspects of the visit like normal. So best ways to recapture HCCs: identify, schedule, and treat patients with chronic conditions as needed, using annual wellness visits or physicals to capture a total view of patients and all the appropriate HCC diagnoses. Use diagnosis insights, which we'll talk about here in a little bit, to identify past and suspected conditions and recapture those conditions where appropriate. So reject any HCC diagnoses that are no longer applicable to the patient. Additionally, we have an HCC indicator on or in the problem list to identify diagnoses with HCC values. So these are those diagnoses that will contribute to the patient's risk adjustment score. And then reschedule patients that may need more time to discuss their chronic conditions and fully capture additional HCC opportunities. So let's say a patient comes in with a broken arm and you realize that day we just want to treat their broken arm. We don't want to talk to them about, maybe there are other chronic conditions that we have, saying, today I'm going to make sure you're taken care of and we fix your arm, but I'm going to have you back in a couple of weeks once you're feeling better to talk through, some of your chronic conditions and how I can help you. So HCC cadence is an annual recapture. We kind of laugh and say, on January 1st, it's the magic healer. All scores reset to just include the demographic. If a patient has had a below the knee amputation, CMS somehow believes that the leg has grown back. So we have to capture these chronic conditions at least once every calendar year to ensure that our patients have the accurate risk score every year. So what are our HCC tools within Cerner? So we have diagnosis insights, which can be selected in the provider view, and it'll show you any prior diagnoses or suspected diagnoses, as well as what diagnoses have been completed or rejected this year. So for example, this patient here has chronic kidney disease. You can see it's listed as either moderate or severe. This is kind of low-hanging fruit because you can determine, do they have stage 4? Do they have stage 5? What was documented in the past? You can see when it was documented in the past. And then whichever condition doesn't apply to the patient, we have our providers click reject, and then you'll have to choose why you're rejecting. So this case, it would be no longer applicable to the patient, but then documenting on the problem list which condition is appropriate. And then the suspected conditions are pulled into the patient's chart through supporting facts. So whether it's been documented by a different provider in a previous year, or they had a lab drawn and their lab's elevated, or any sort of imaging, it could pull in. So let's say a patient has never had a diagnosis of diabetes before, but then they get labs drawn and their A1C, is greater than 8, indicating they may be have diabetes. That would pull into this suspected category there as kind of a flag. Hey, this lab was elevated. Should we be documenting that on the problem list? This is a good tool for your toolbox, just to help kind of keep track of chronic conditions and making sure we're addressing all the conditions that are appropriate. And then I'm sure you're very familiar with the problem list view. You can see here which conditions have HCCs listed next to them, which are contributing to the patient's risk score. Something else that'll have help with this is this problem list component. So when we're typing to add a new chronic condition to the visit, you can see here conditions that have this R indicator next to them are risk adjustment conditions that will contribute to the patient's risk score. So diagnoses that are included under one of the HCC risk categories will have that icon next to them. And again, it's just a tool in your toolbox to help pull in those diagnoses that will contribute to that score overall. And then documentation, this goes back to the meet criteria. So addressing those HCC those conditions, and then using the meet criteria to have that appropriate documentation. Okay, I went through that very, very quickly and fast. I am happy to answer any questions that you may have. I also would love to, if you're interested, pull up a chart in Cerner to look at what that might look like for a test patient so you know what you're viewing. So I'll stop sharing for now and answer any questions that the team might have. All right, fairly straightforward.
So Abby, I'll ask a couple of questions just to kind of
Sure.
get things started.
Sure.
Do HCC codes apply to both ambulatory practice as well as inpatient? So for the residents who are going out, not anticipating doing inpatient coding, how will that affect them, and how does that apply?
Sure. So that is one of the things that are on our, future list, is to engage with specialists. Specifically, we're looking at, if a patient, let's say cardiology, for example, is on our list, or nephrology, or oncology. So at first, we're engaging with providers who, if patients have really severe chronic conditions, who may ultimately, if a patient has an oncologist, for example, or has cancer, that oncologist may end up becoming kind of like their primary care provider and taking over the majority of their care. So in those specialties, yes, HCC diagnosis will be eventually coming out to them, and we're actually looking at engaging specialists there. As far as on the inpatient side, like hospitalists, or roles like that, I'm honestly not sure. I don't believe so at this time. We're looking to engage. It's more providers who have longstanding relationships with their patients and who are managing these chronic conditions.
Yeah, so I guess I'll just throw in there that while the HCC code emphasis is on the physicians with a long-term relationship, that this all ties back into the basket of correct and accurate coding. And correct and accurate coding has tremendous impact on the revenue to the hospital, the revenue to the clinic. And not only is it about money, but it's also about clearly communicating to other people involved in the care of the patient. So one of the things, like we as physicians, us as family, you're speaking to an audience of family physicians, have a couple of primary responsibilities to our patients that we cannot delegate or should not delegate. One of those is building rapport with our patient and fostering a great therapeutic relationship whenever we can. The second is accurate diagnosis. As a physician, that is a role that falls onto us to diagnose accurately and to start the process of creating an appropriate treatment plan. And that accurate diagnosis is what you're speaking to today, Abby. Would you agree?
Absolutely, yes. And I think you nailed it on the head that it's really, truly not about money. It's about making sure that our patients' risk scores are accurate so that we have the resources to care for them. So, you know, if a patient is truly healthier and we don't need those funds to wrap around them as much as we do, you know, a patient who's more at risk, that's what we want reflected in the chart, you know, the accurate risk score, whether it's 0.5 or 2.7, making sure that we're just collecting those chronic conditions and validating annually. Absolutely.
Abby, this is Kristen Steiner. I'm a second year resident here. I just trying to wrap my head around this, and I'm sorry I kind of came in. I think I missed the first part about what this all entails. But for the coding, is this saying that with each encounter with the patient that we're documenting all of these issues, or is this just kind of in the background of the chart?
Yeah, so it's not every encounter with the patient, but we do have to accurately document their chronic conditions annually. So it's once a year saying, you know, having those annual physical with the patient or the annual wellness visit with the patient to say, and obviously, like, let's say a patient has uncontrolled diabetes, we're seeing them more than once a year, but making sure that we've captured that chronic condition at least once per calendar year, so that it's pulling into that patient risk score. Does that make sense?
Yes, that does. Thank you.
Yes, absolutely. And I'm trying to pull up a test patient for you guys quickly so I can look through. I'm just having some issues here. I apologize. I will find one now. Okay, so I'm going to share my screen again. So let's say this patient here, this is actually not a population health patient, but I'll still use her as an example. So you can determine if a patient is a population health patient through this PHSA yes, and determine if they fall into a Medicare patient, MA patient, or ACO patient, or in our Aetna MA plans. We are growing as far as what patients will pull into this population health category, but that's going to be your indicator of which patients we're primarily focusing on at this time. But I just wanted to have an example for you. So if you go to components here, you'll see diagnosis insights here. So sometimes when providers go in and they don't see diagnosis on their insights on their view here, it's because it simply is not checked here. So that'll want to be the first thing that you do. Is check it here and make sure it pulls in. We also have prior diagnoses and suspected. So you can see, you know, on November 23rd, 2020, this patient had this condition documented, and you can even click it, looked at prior diagnoses, what's causing this to pull into diagnosis insights here. Same for suspected. So you can see diabetes with a complication or without complication. You can see the A1C is pulling this 11.3 for uncontrolled for an uncontrolled A1C lab. Also, this is pulling in medications, which may indicate major depressive, bipolar, or paranoid disorders, and then show you the facts here. If you're ever curious, you can go back, of course, and look through the chart to see, you know, if you're like, I'm not sure they have this, you can do some chart diving here. Let's say, I'm not obviously going to reject any of these really, but let's say you were like, no, my patient doesn't have that condition. You would click reject there, select a reason, whether that's disagree with suspected, no longer applicable, or other, and then you can free text here, of course. And then, of course, For the problem list, you can see previous diagnoses that have been captured that haven't been addressed this year will turn red on your problem list, indicating that they still need to be addressed in this calendar year. So there's kind of multiple tools here to help you address any conditions that haven't been yet in 2021. Then again, it'll show you completed this year, as well as what conditions have been rejected. Just wanted to give you a brief patient to look at and a patient example. Any other questions regarding diagnosis insights? I'm also available if you are working through this, working through your list, checking through patients, and you run into any issues or any questions. I am more than happy to meet one-on-one to look through patients' charts with you, or just address any one-off questions that you may have.
It's Kristen Steiner again. I just wanted to say that was super helpful to know why part of them are red. It's always bothered me. So now that I know the key, I think that's super helpful. So thank you.
Yes. Yeah, no problem. And yeah, as soon as you address it in the patient chart, it should turn black after the claim's been sent out. But if providers have had issues in the past, for example, where they've reached out to me and they've said, can you look into why this condition hasn't turned black yet, even though I've addressed it, and things like that. So that's kind of some of the back end stuff that I am here to support you and make this work as easy as possible for you to do going forward.
Abby, I'm sorry if you already said this, but do you send notification then through Cerner that we have some diagnoses that we need to look at, or is the main way that we get the communication by looking at that specific list?
So what I've done in the past, and I'll defer to you on what your preference would be, I do different things with the residency clinics compared to, since residents see some of your patients that might be on your panel. But I do send lists, and I'm happy to start doing that at the beginning of every month with patients who are in order of when they're due to be seen in the office. So as they're coming in, oh, this patient, it says patient name, MRN, date of birth, next PCP appointment, last PCP appointment, and number of outstanding conditions. And so, for example, for IMRC, the attribution's a little bit wonky because you obviously have residents seeing some of these patients instead of the attendings. So I send them a list that's just a total list of patients coming in, and then they divvy it out for who it belongs to. Whereas at MIM, I might send a list directly to Dr. Koss because he's seeing his patients and he doesn't have somebody else who may be seeing those patients. So if that's your preference for me to send either broken down by provider, and then provider can kind of say, okay, my residents are seeing these patients this day, or I'm seeing these patients, or I can send you a total list and you can break it up that way. It just depends on your preference. But I do provide those lists so you know which patients to document on, or which patients are coming in with outstanding conditions.
Okay, thank you.
Mm-hmm. And Tina, I can work with you on that. I think, when I spoke with Donna, she said we tried it a couple different ways depending on what worked, and we ultimately found one that worked really well for them. So happy to kind of do a trial and error until we determine what's the best fit. I see your note. Sounds good. Okay, perfect. Thanks, Tina. All right. Well, that was all I had for you today. Thank you so much for your time. I really appreciate it. I, again, am here to support and make this work as easy as possible for you. So I am always available for questions or for outreach. I can pull that list today and send it over to you, Tina, with patients coming in with outstanding conditions, and then any risk lives that haven't been scheduled yet in 2021, so we can get them on the books, if that sounds okay.
That sounds great. Thank you so much for spending time explaining this to us, and I'm sure we'll have more questions, but we appreciate the introduction.
Yeah, absolutely, not a problem. And yeah, that's usually how it goes, right? As soon as the as soon as you start kind of playing around in charts and doing the work, questions come up. So I will be here to support you and again, make it as easy as possible, and happy to come into the office and round and talk with folks if that's what would be preferred.
Great. We really appreciate it. Thank you so much for spending time doing this.
Yeah, no problem. Thank you guys. Have a great rest of your day, and I'll talk to you all soon.
Thank you,
Thank
Abby.
you.
For those of you who are on, I'll also just ask you to please go and read an email. I sent out an email this morning regarding virtual visits in Amwell Now. And just to kind of give you the punchline, we are getting ready to switch over to use Amwell Now. We will be moving away from scheduling in Amwell. So currently you may get a reminder email or stuff like that from Amwell. And like when patients enter your virtual waiting room, some of you may be getting a text or an email. That functionality is going to change a little bit. And I think once you start using Amwell Now, you will see that this is a different setup. It's a lighter program. It works a little bit more like Doximity Dialer. It's very easy to connect with. The audio and video quality is actually better. And so we will be making that switch over to Amwell Now. And this is going to create a few new processes for the front office, how to schedule. It's going to create a few new processes for MAs. And our goal is eventually to get our MAs as involved as possible in these virtual visits, including the opportunity to collect vitals and to collect a chief complaint and to room and prep the patient for us. That's going to be a work in progress over the next few weeks. So please be patient with that and collaborate with your MA as you work on that together. And I'm open to any questions that you might have regarding Amwell Now or virtual care.
Dr. Witt, it's Kristen here. The one thing that I struggle with, I think hopefully other residents join me here, is just being on time and meeting patients in a timely manner. And I didn't know if there is a way on Amwell Now where the MAs can kind of notify them, hey, we know you're waiting, the provider's running late. I don't know if that's a possibility.
Yes, the short answer to that is there is a mechanism by which the MAs can be on that visit. And just for clarification, I'm not sure if you mean if you run behind in the real clinic and how that will translate, or if you run behind in the virtual. But I think the biggest pitfall that I have personally experienced is having live patients in clinic and then having virtual patients to follow, and that it's really hard to run on time. Interestingly, I wouldn't have predicted this necessarily, but I found that on virtual visits themselves, I actually tend to run on time really well. And I think it's just that with that virtual environment, I'm not as chatty, and I'm less likely to just sit and shoot the breeze with them. But I tend to move through those visits really. Plus, they're scheduled for 30 minutes. Technically, they're scheduled for 15, but we're giving a 15-minute block afterwards. So it's on a cadence of every 30 minutes, as opposed to the in-person visits of every 20 minutes. So I think once you get in a virtual flow, like say you have 3 or 4 in a row, that you probably will find that you run on time pretty well with those. Others can tell me if I'm wrong. I think the bigger issue is if you have a live visitor, a few, and then you have a couple of virtuals at the end. That can be tough. But again, where we're moving toward is to have the MA rooming the patient. And so the idea is when the MA rooms the patient, they might say, well, Dr. Steiner is with her last patient of the day here in the office. And so she may be a little bit late. The MA would stay with that patient until you're able to join that visit. And again, there's still some process steps that we need to work out. It's new for all of us. So I don't think we have anyone that knows all the answers, but we'll work through that. And I think in the long term, you might have a virtual clinic session. You can jabber or communicate back and forth with your MA to let them know if you are having an issue, a glitch that puts you behind. You can communicate that back to your MA, and then they can communicate it to other patients.
That's helpful. Thank you.
Open to any other questions. Happy to stay on for a couple of minutes. Abby, thank you again. You don't have to stick around if you want to get off.
Okay, great. Have a great day, you guys. Thanks.
Dr. Witt, I don't know if you saw the question on the chat. How do virtual visits work as far as computer screens go? One computer set up in the room that MA and provider use.
Yeah, good question. I have, to be honest, I haven't thought through that answer. I think that for me, part of the reason I haven't thought about that is because as a director, I often do the virtual visits from my office. So I'm using a whole different set of computer and monitors. MAs do have their own laptops, and I see Tina just put in the chat that the MAs will use their laptop. So I think as a resident provider, that it would work well to do virtual visits from one of the exam rooms. And both sides, A and B, have about half of our exam rooms are set up with a dual monitor that you could plug into your laptop and be able to function. And you basically just function out of that room for the entire virtual session, no matter how many virtual patients you have. So yeah, you wouldn't share that computer with the MA, they would be using their own laptop. I think that probably answers the question. And with the multiple screens, when you plug in the multiple screen, or you plug in that dual monitor to your device, if you are seeing the exact same screen on both monitors, all you need to do is to right click on the backdrop, basically the display of your monitor, right click, and then I think there's an option for display settings. And you scroll down a little bit and you can change from duplicate displays to extend these displays. That's going to give you where you have screen 1 and screen 2. And you know, the only tricky thing there is which one's actually on the left and the right. And so you can switch that if you need any help. If you ever want to be shown how to do that, let me know. But when I have the dual monitor setup, I like to extend the display so that I have truly two monitors. I put AmWell Now up on one screen and I put Cerner up on the other. It's a matter of preference. I tend to put Cerner up on my laptop because I want to be making eye contact with the patient more. And I guess I don't sit there and watch the patient on the video, but I have been known to switch the screens if the patient if it's a little bit more in-depth conversation. I might put the patient over right here on the laptop so that they're near the camera. But a lot of times I'll move through the visit with Cerner front and center, and I can see the patient out of the periphery of my vision. So you guys can play with that, figure out what you like. Let's see, so the next question I'm seeing here is one video session or two different video sessions. So the way AmWell Now is set up is that you can, it's like three-way calling. The MA can establish the session with the patient. When they do that, they put in the patient's phone number or their email address. And whichever contact information they put in, determines how the patient gets a link. They'll either get a link in their email, just like if I send you a Zoom link and I email it to you, or they'll get a link on their phone that'll come as a text message. And the ones I've done so far, I've sent to the mobile phone, and the patient will click the link on their phone. The link says something to the effect of, you are invited to join with Dr. Witt for a visit, something like that. And they click on the link and it connects them into the session. So once the MA does that, they establish the session with the patient. They can then do their part, however long that takes, a few minutes. They can then add the provider into the visit, at which time you will receive a link. And then when you click on that link, you'll be added into the session, kind of like a three-way call. And then the MA will be able to leave the session. And now it's just you with the patient. So it's just one video session, but people can come in and out. And this is the way it works when you do a handoff with behavioral health, for instance. You can, now you have to know who to send an invite to. You have to know who's available. That's one of our barriers. That's going to be a process challenge for us. But once you know who's available, you can link them in. You say, invite another provider. You select their name and they get a link. They join the video at that time. And then you can provide an introduction, just like you might in the physical environment. And then you can step out of the visit. Or if it's a visit, maybe you're going to co-facilitate counseling session, you can stay in and co-facilitate. All right, I'm not hearing any other questions. Thank you so much for sticking around, those of you who did. And if you think of a question later, come by my office or drop me a line.